I usually start by, in a context like this, by saying, hi, my name is Dean, and I'm an economist. And no, there isn't a 12-step program to cure me from that. But I think I've learned from Lou that maybe I can do it in 4 steps. I just don't know which 4. So I was asked to react to this morning's remarks from the standpoint of, what does this mean for comparative effectiveness research? We are now on a path with a new government agency to spend $1 trillion over the next few years on comparative effectiveness research. And listening to this morning's conversation, it's quite apparent that they never thought about implementation science or the concept of implementation science during this thought process at all. We are debating whose list of 100 drug A versus drug B priorities we should be spending $1 trillion on, with seemingly no thought at all to, if we do decide that drug A is better than drug B, we're going to get it prescribed. I have the pleasure here at the university of sitting on a committee that looks at what drugs get provided on the formulary. So if someone doesn't like that your drug isn't on the formulary and you have Premier Care, you can come and talk to me afterwards, and for a small fee we can. No, and actually over time the research that's been done hasn't addressed the implementation science behind drug A versus drug B, but somehow we've managed to get through that process anyways. Because in every insurance company and every institution, we have formulary committees, and people somehow look at the evidence of drug A versus drug B, and they make pretty quick decisions about what's covered and what's not. And it doesn't hurt us that much because, I say this in the old Pfizer cafeteria, it's mostly about anonymous drug companies in New Jersey, right? It's not about what we do on a daily basis. On our own health benefits committee here at the university. So again, if you don't like the fact that some surgery you want done isn't covered by the health benefits, we can talk about that later as well. But we struggle greatly with having the evidence, and people talk about there being a lot of evidence out there for what is appropriate services and what aren't. And at our monthly meetings, I can tell you that that's generally not the case. We have a lot of good randomized controlled trials that have said in 51% of the patients, service A was better than service B. That 51 versus 49% mean it trumped it. But when we read the studies with any sort of nuance, they do come up with this, well, in 51% A was better and 49% B was better, without much indication of, well, if I'm Mr. Smith, and thank you, Professor Yates, for bringing up the example of prostate with Mr. Smith. I then worried I have to call my urologist after this meeting. I don't know if I would be the person that fits in the 51% that gets the better service or the 49% that was something else. Clinical nuance is something that is probably deep in the minds of clinicians, is probably deep in the minds of people doing studies, but it's not what gets published. What gets published is service A was better than service B, not the sort of nuance behind it. I'm also reminded regularly at our medical benefits committee meeting that I'm one of them, not one of us. I'm the token non-clinician at the medical benefits committee meeting. And so when we get new results, and the controversial one this fall is going to be about prostate, about PSA testing for prostate cancer. And we have a Preventive Services Task Force which said routinely people shouldn't get PSA testing unless they have family background because the process of going through the testing is more likely to lead to harm than good. And so proudly I went into our last meeting and said, good, we'll finally stop providing this, this wasteful test. And after they laughed at me for a few minutes, they said, you naive boy. In medicine, it's first, do no harm. Second, harm no doers. You might have to show with 95% confidence that some new service is worthwhile, but you have to also show that there isn't some 5% of people out there who wouldn't benefit from something we're already doing to get a cut. We're going to have a very lively debate, which I expect will not be focused on the evidence and not be focused on implementation science about prostate cancer screening, because my understanding is that could be 35% of the revenue for a certain department here at the university. And thinking about how then we do something different is a challenge that I'm not sure we're up to the task for, even with the information. The final point I'll end on here before I get thrown out of the room. The last time I spoke at a conference before Carolyn Clancy was about this PCORI issue and this comparative effectiveness research. And I think I said something like, isn't this a crazy idea that we're going to spend $1 trillion? And the reason we get to do this research is because of a compromise that was made between the political parties, that as long as we didn't consider cost in any of these considerations, and we didn't do any cost analysis in this comparative effectiveness research, that we could go ahead and do the research. And so we're going to spend a lot of money, and hopefully someone on the side, someone in implementation science, will think about, if we do follow these recommendations that come forward, that cost will somehow be included. I get involved with a number of clinical and social service and public health programs where they're comparing different forms of treatment or different interventions. And someplace, not usually at the start, but halfway through the program, someone says, gee, I wonder if this is going to be expensive. Or I wonder if cost matters. Or I wonder if we do find that asthma treatment program A is better than asthma treatment program B, anyone is going to bother to implement it unless they know how much it costs. And I'm somewhat embarrassed to say that the majority of studies that I get involved with end up being more expensive than they're worth. That is, the cost of the social intervention ends up being much more expensive than what is perceived to be the social gain. And therefore, while I'm proud to have 100 plus publications, it might be 200 if only the results came out a lot nicer. But results often don't come out nice. And we talk a lot about, wouldn't it be great if we knew about the failures? I can be happy to tell stories if people want to ask questions about many public health interventions where we've done a study, the result has come out negative, and we've been told directly by the editors, well, just throw it away. Because a negative result will not get published. It is against the orthodoxy of our field to say that what we do isn't effective, so forget about it. And usually I do. I may grumble a little bit, and but that's what I do. The final point I'll mention was ending on Ann's note. I spent the last 7 years being a senior associate dean, and one of my responsibilities was the tenure promotion process of the school. And I think if we do follow Jeremy's suggestion that we ban theory, in the short run we'll save a lot of money because we won't have to pay people associate professor salaries because they won't get there. Sadly, we're in, I'm not sure it's sad, but we're in a culture where having not an innovation that is moving things incrementally along better is rewarded as much as blatant invention. And invention means a new theory, people haven't thought about it before, in hopes that it will be the next best thing since sliced bread. And I think when I look at the tenure promotion cases that came up each year, almost everyone had an R01 from an appropriate agency and at least one or two papers that were a new theory, not just the applied work and implementation activities, but a new theory that made them somehow unique for at least the half an hour that it took a reviewer to write a positive letter for them. And so I'm going to echo your comment that we might, at Michigan, as a leading place, think about how we innovate and move our own internal process along that reward implementation, science, and evaluation more. Back to you, Lee.